few minutes. Oh, there's a friend. If you could, minutes, a few minutes after the hour, would that be a cardinal sin?
No, not at all. Not at
Like
all.
I am
No.
not going to be ejected and
No.
okay.
Not at all.
Like I won't have the police at my door.
No, nope, not at all. Yeah.
Now that I told you where I live.
Yeah, exactly, exactly.
Okay.
Well, welcome everyone. It is my pleasure to introduce today Lorena Drago, who is our speaker that we're going to have today. So just to preface it a little bit, my name is Bridget Eidecker, and I am a diabetes program planner at the Minnesota Department of Health. This webinar is provided by a collaboration between the Diabetes and Health Behavior Unit and Healthcare Homes of MDH. Funding is provided through MDH's CDC grant 2320 AHEAD, which we have named AHEAD to be Advancing Health Equity and Diabetes. Lorena Drago, MS, RD, CDN, CDCES is a registered dietitian, speaker, author, consultant, and certified diabetes care and education specialist. Lorena specializes in multicultural aspects of diabetes self-management education and is an expert in developing culturally and ethnically oriented nutrition and diabetes education materials. She founded Hispanic Foodways, which received the New York City Small Business Award in 2006. Lorena served on the Association of Diabetes Care and Education Specialists Board of Directors from 2006 to 2010, Chair for Latinos and Hispanics in Dietetics and Nutrition. She was the past president of the Metropolitan New York Association of Diabetes Educators in 2004. Lorena won the Diabetic Living People's Choice Award in 2012, the Latino and Hispanics in Dietetics and Nutrition Trinco Award in 2016, and she was also named the Diabetes Educator of the Year in 2022. She's authored several books that have been published by the American Diabetes Association and the Academy of Nutrition and Dietetics. Lorena is chair-elect of the Diabetes Dietetic Practice Group and the Academy of Nutrition and Dietetics. Lorena graduated cum laude from Hunter College, from Hunter College of the City University of New York with a master's degree in science and food and nutrition, and her bachelor's degree is from Queens College. Before we start today with our presentation, I want to do a couple housekeeping things. As you're entering, your phones are going to be muted upon entry. Please put your questions in the chat, and also this webinar is being recorded. And how we'd like to start all of our presentations, we would like to do the Tribal State Relations Acknowledgement Statement. Every community owes its existence and vitality to generations from around the world who contribute their hopes, dreams, and energy to making the history that led to this moment. In Minnesota, we are standing on the ancestral grounds of the Dakota people. We want to acknowledge the history of this land, including the Dakota, the Ojibwe, the Ho-Chunk, and the other nations of people who call this place home. Native peoples were removed unjustly, and we see this space and in this space are the beneficiaries of that removal. At MDH, as we understand that land is related to health, we want to be a good steward of the land we live on. This acknowledgement is just one piece of that. We understand that systemic racism, historic trauma, and genocide have impacted Indigenous communities and peoples in our state. We recognize that a land acknowledgement is the first step. We support this action with resources and shared decision-making to meet tribal public health priorities and needs. With our Indigenous neighbors and coworkers, we can advance health equity and work to ensure all communities across the state are thriving and all people have what they need to be healthy. We encourage state employees and the public to research the history of the lands we are on, and if you are able, find Native-led events to attend, organizations to support, and causes to champion. And without further ado, I am going to pass it over to Lorena.
Thank you so much, Bridget, for this invitation, and let's begin. So the title of this presentation is Improving Prediabetes and Diabetes Health Outcome. Next slide, please. These are the objectives of today's presentation. And let's move on. So this is the definition as per the CDC of what is health equity. It's the state in which everyone has a fair and just opportunity to attain their highest level of health. Next. Next.
Stand by, Lorena. I think we're having some technical difficulty with
Okay.
Bridget. I will get slides up here for you. All yours, Lorena. Or go ahead, Lorena.
Okay. Next.
You're right. We're both having. There we go. Stand by. There we go.
Okay. So when it comes to prediabetes and diabetes, it means that everyone has a fair and just opportunity to prevent and manage prediabetes and diabetes regardless of their socioeconomic status, educational attainment, age, race, ethnicity, income, or environment. Next, please. So I'm going to start by sharing a true story of a Nigerian male adult diagnosed with type 2 diabetes who reached out to me requesting a nutrition consultation. He has Medicare with United Healthcare, and he scheduled a consultation as usual. Everyone who schedules a consultation with me receives ahead of time several forms to fill out prior to that consultation. And throughout this session, I am going to go over what are various barriers and what are the results with health equity, and how do you fill those gaps? So next slide, please. So these are some barriers to health equity. And certainly these are not all, I am not encompassing all of them, as I would have to show more slides. But here are race and ethnicity. And as you probably have heard, if you have been in practice, there are disparities when it comes to prediabetes and diabetes with certain racial groups, such as Hispanics, Asians, as well as American Indians. And the same thing when it comes to diabetes technology, health insurance, age, food and nutrition, physical abilities, geographic location, educational background, economic status, and language. Next slide, please. So let's go back again to this patient that has Medicare, is a Nigerian male. And so right away, there might be some possible barriers to health equity. And without even reading some of the forms that he already has filled out, next, please. There might be some technology because I had emailed him some of the forms, and that is part of just scheduling the appointment. There might be some food and nutrition barriers. There might be some disability, and that's because he's a Medicare recipient. He's an older adult. Are there some economic status issues? After all, he may be retired and there might be some economic issues. So those are the things that I am thinking about. Next. So what key questions can you ask during that assessment to identify potential health disparities? So that's one thing that I immediately try to anticipate because I want to bridge that gap and reduce health disparities. Next. So some of the questions that I want to ask during that assessment is, do you have access to the internet, whether it's via the phone, a smart tablet, or a computer? What about diabetes management apps? Would you be interested in more virtual visit or even digital tools to help manage your health? Are you interested in using a continuous glucose monitor or biosensor if it's someone with prediabetes? So asking these questions will be an important way to assess whether this person is ready for more information, or also to understand where this person is at this point and identify potential health disparities. Next. Now, one thing that I wanted to share with you is, where are we when it comes to diabetes technology health disparities? And I wanted to share this study with you. And this is the other end of the spectrum. With my patient, it was someone who was a person over the age of 65. But when it comes to the search for diabetes in youth study, they found that there were these disparities. Hispanic patients use insulin pumps half as often as white patients. Black and Asian patients use pumps only 1/5 as often as white patients. And most pump users came from higher income families. More than 75,000 a year had college educated parents and private insurance. Next, please. So one thing that you're going to see throughout this presentation is I am going to present some of the barriers. Those barriers create some health disparities. And the third part that I want to show you is, how can you close the gap? What are some things that you can do that are actionable to help you close the gap? So in this case, it may be lack of knowledge. It might be that someone doesn't know when something is available to them. For example, someone may not know that how to access a biosensor. They may not know how to access a CGM. They don't know that there are diabetes apps that exist that they can use. In the case of my patient, they are unable to interpret glucometer readers, the readings. So there is an inability. They have been given a glucometer, but they don't know what those numbers actually mean and how to take actionable steps. So what health disparities do can occur? Well, the glucose is out of range, the A1C is out of range. So how do you close the gap? You discuss the technology, you teach how to interpret the glucose readings, and you teach the A1C goals. Now, the technology barriers, where do they stem from? You need to understand the root cause. Well, sometimes it stems from the patient, but they also stem from providers and the healthcare system. I want to dig a little bit into it and tell you where I have seen those occur and also what the literature says. For example, when it comes to younger Hispanic patients, literature has shown that they are apt when it comes to learning about the use of aids in diabetes management. However, they lack support in the household. So they discontinue using CGMs and insulin pumps even after they have initiated because of lack of support, not because they don't know how to use it. That's an issue with patients. Now, providers sometimes act as the gatekeepers of who is referred or recommended or prescribed technology. Many times they feel that the patient may not be responsible enough, or they may not have the support that it's needed. So they act as the gatekeepers. There is also an issue with finance. The patient may lack insurance or the right insurance, so they do not have the prescription. There are system level barriers when it comes to providing them with the correct aids that they need in terms of insurance. And they also may have higher, and I mentioned this, higher co-pays that they are unable to afford. So all those barriers may exist from the patients, the provider, and the healthcare system. As you can see here, Black patients with type 1 diabetes face significant risk, have the usage of insulin pumps compared to white patients, and they also have other issues. 3 times the higher risk of hospitalizations for DKA and hypoglycemia, and the A1C is 1.5 times higher. So those things existed. Even it's not just technology, because those things existed even when there wasn't technology. So there's clearly other issues that are at hand. So how do we close the gap? Education, training, referral, support, and in the case when we have individuals that do not speak the language concordance also helps. So those are, I want you to focus on what can we do to close the gap. When there are barriers, what disparities do they create, and also how do we close the gap? And we're going to see more examples about closing the gap. Next, please. So here is another real life example of a colleague of mine that works in Phoenix, Arizona. She works as an inpatient dietitian, had a consultation by the RD, and the first thing she tells the RD is, I am not Mexican, I am Puerto Rican. And Phoenix has a large Mexican ancestry population. So next, please, Bridget. What cultural barrier has this patient experienced in the past? And I am going to ask you to write it in the chat very quickly. Why do you think this patient tells the dietitian, the first thing she tells her in English is, I am not Mexican, I am Puerto Rican? What do you think happened there? And she told me this story because she knows that I talk a lot about cultural issues in diabetes management. So what do you think happened? And someone just wrote, I don't know. And that's totally fine. Okay, someone said assumptions about food culture. Okay, anyone else? People assume that she's Mexican. Yes, obviously. No, she said it in perfect English. This wasn't a lost in translation. Established identity, prejudge about heritage. Okay, okay. About her diet and culture. Okay, just for time's sake. Next, Bridget. Okay, what health disparities can this create? Hispanics don't like to be confused with another country. The food culture is different for Puerto Ricans. Correct. That's the correct answer. Because it's different. Because we don't eat the same. That is correct. That was the correct answer. Next. Okay. And how can you mitigate the cultural health disparities? Next, Bridget. Okay. So I am going to talk a little bit here about my patient, and I'm going to talk about this other patient and why the first thing that she said was, I am not Mexican. So my patient was Nigerian, and here I am just going to do a compare contrast of Nigerian foods, American foods, and this is just starchy vegetables. That's it. And that's because they contain carbohydrate. And just to do a comparison of the main starches with Nigerian foods, American foods: corn, potato, sweet potato, pumpkin, butternut squash, yam, cassava, plantains, green and yellow, sweet potato, cocoyam, which is also taro. Now, when I say yam to you, what do you think yam is? And you can write it on the chat. What is yam? Sweet potato, sweet potato, sweet potato. Okay, perfect. Now, how can you close the gap? These are some of the things that you can ask. Tell me about the foods you eat. What are your favorite ones? Which ones can you buy here? And that's if someone is from another country. And the reason is that they may be going to international markets. They may be going to certain places where they can find some of the foods. Another thing that you can also include in your own assessments is sometimes they cannot buy certain foods, but you can find them frozen. And frozen is, and March, other than National Nutrition Month, is also National Frozen Foods Month. And you cannot find certain foods like soursop, which is a fruit, and cassava. So you can also find resources using generative artificial intelligence. So you can also use any Perplexity, Gemini, ChatGPT, and also don't be afraid to suggest nutrient-dense substitutions. So I'm going to show you what yam is, not just for Nigerians, but also for Caribbean Hispanics, Puerto Rico, Dominican Republic, Cuba, as well as for certain South American countries. And next, Bridget. Okay, so this is gari, which is cassava, and it's made out of cassava, which in Spanish is yuca. And this is used in Nigeria as well as in other countries in Africa. Next. Okay, this is yam, what I'm holding here. So this was, I was doing a social media presentation. Yam is called, this is the real yam. It's not sweet potato. It is a starchy food, and it is used in the Caribbean. It is used in South America. I'm Colombian, and I am Colombian from the Caribbean coast. So we use yam, and it has a lot of resistant starch. So that I was doing a TikTok video about yam because it has resistant starch. Okay, next. And this is cocoyam, number 5, which is taro. So that's basically it. Now, I know that many times when it comes to talking about cultural foods, many times we don't want to deviate from suggesting nutrient-dense foods, i.e. brown rice instead of white rice. But I think it is important to make suggestions and offer. It is okay to suggest brown rice because, after all, many people from different countries have learned how to eat hamburgers, they have learned how to drink soda, and they have learned how to eat pizza. And I can guarantee you that those were not cultural foods that we learned how to eat in our own countries. So I'm sure that it is okay to suggest nutrient-dense foods. Next, please. So, knowledge about dietary practices from different countries, that might be a barrier, which the health disparities would be high blood glucose, elevation in A1C, and then providing nutrition care that addresses the patient's backgrounds, health beliefs, and practices. Next. So, we're going to talk about the social determinants of health, and there are 5 pillars. And we are going to, now I'm going to address how to address each one and how to close the gap with tools, just like some of the questions that I have been sharing with you that you can ask during an assessment or that you can utilize in practice. Next. So this is the definition as per the CDC. This is the most current one. The conditions in which people are born, they live, they learn, they work, they play, they worship, and age, that can affect a wide range of health, functioning, and quality of life outcomes and risks. Next. In the United States, 1 in 10 people live in poverty, and many people can't afford things like healthy foods, healthcare, and housing. Next. So the access to healthy foods, food insecurity, food and nutrition, I added one more, which is the food and nutrition misinformation and disinformation. What are some of the health disparities that can occur? It could be overweight, obesity, underweight, eating disorders, disorder eating, malnutrition, hyper or hypoglycemia, hospitalization, or high cost utilization. How can you close the gap? How do you know how to address this barrier? Well, you can use the hunger, perform the hunger assessment. You can use the newest vital signs screening tool, and that will be to assess health literacy, education and training skills, use resources, and also referrals. And we're going to go over those things so that you can address them and ensure that those things is something that you can use in the future. Next. Okay. So here, this is a form where you can test for a person's health literacy. So we're going to cover health literacy in depth in a few slides, but health literacy is the ability to interpret health information. And health literacy is very important because many times, many of our patients may not be able to interpret or may not be able to use health information and put it into action. So this newest vital sign is a way that you can use to test to see if your patient is able to interpret health information, whether it's numeracy or prose in general. So what you do is you take a food label and you ask 6 questions. If you are in a rush, I would just want you to ask just a few questions. And you don't have to answer this, but take a look at the nutrition facts. And if you eat the entire container of ice cream, how many calories will you eat? How many will that be? And if you are allowed to eat 60 grams of carbohydrates as a snack, how much ice cream could you have? Can you answer those 2 questions correctly? So if you can answer those 2 questions correctly, then there is a score sheet, which is here. If you answered 4 to 6 correctly, almost indicates adequate literacy. Next, please. And here you have the answers correctly. So if you want to know if your patients have adequate, poor literacy, limited literacy, then you can use this in your practice. Next. Now, this is the Hunger Vital Signs screening tool. This you can use, and it has 97% sensitivity and 83% specificity. And you can assess whether your patient, your clients, have any kind of food insecurity. Within the past 12 months, we worried whether our food would run out before we got money to buy more, or within the past 12 months, the food we bought just didn't last and we didn't have money to get more. So these are 2 questions you can include in the assessment. And I'm glad to say that many times when I and my mother have been to see a doctor, or we have been in a hospital setting, we have been asked these questions. They have been part of the assessment. Next. Now, I want to go back to Medicare Advantage beneficiaries with type 2 reported 1 social determinant of health in a health-related social needs service. So we know that the most commonly selected SDOH were financial strain, food insecurity, poor housing quality. And higher, when there is food insecurity, then we know that it's linked to higher rates of emergency department visits, inpatient encounter, and avoidable hospitalizations. Next. So another area that I wanted to include here is, I find, and many of you will probably agree with me, that there is a lot of misinformation and a lot of disinformation. And the difference between misinformation and disinformation is that when you have misinformation is false, inaccurate information, and disinformation is when it's false or misleading information. So I wanted to give you the top 5 misinformation about diabetes is on the left, and the disinformation is on the right. And for example, people with diabetes can't eat fruit. Diabetes-friendly label foods are always healthy choices. Type 2 diabetes is a mild form. It's not the bad diabetes like type 1 is. And people with diabetes can't eat sugar. And if you have diabetes, you will lose a limb or go blind. These things, especially when someone has not seen a healthcare professional that talks about diabetes management, it's really, really damaging because they will not make good decisions about their management. Now, the disinformation, it's really terrible because they will have claims of miracle cure, like for example, cinnamon would be the miracle cure. They may not take some of their medication or take it sporadically. Restrictive or unbalanced diets of things that they cannot have. They can create fear or distrust. Like, for example, Big Pharma is hiding the cure for diabetes. There's fear, there may be fear of insulin, or doctors and dietitians don't want you to reverse the diabetes because they're profiting for you being sick. And the use of social media to promote non-credentialed individuals as reliable sources of diabetes, because they know the cure, and they don't want you to know it. Next. So I want to ask you, what percentage of diabetes and health nutrition information on TikTok is accurate? Can you put it on the chat? What do you think? Five percent, 15%, 50, less than 10, 10. Okay. Okay. 20%. Okay. Next. Bridget, 10%. Okay, only 2.1 of health and nutrition information on TikTok was found to be accurate when compared to established health and nutrition guidelines in a study using artificial intelligence to analyze over 67,000 video. That's very scary. So the one that did 5%, you were the closest one. So that's unbelievable. Next, Bridget. And one study evaluating the hashtag diabetes management content on TikTok found 46% posts were accurate, 28% posts were partly accurate, and 26% posts were inaccurate. And in a sample of 171 diabetes-related videos, only 1.2% were created by healthcare professionals. So now you know what to do immediately after you're finished with this webinar. Next. So what are some of the questions to close the gap when you want to know about what your patients are doing? And this is what I have in my assessment when I schedule patients. Which foods and beverages do you eat or drink to make you healthier? Which foods and beverages do you eat or drink to help you manage your diabetes? Which foods and beverages did you stop eating or drinking now that you have diabetes? And are you taking supplements, herbal medications to manage your diabetes? By asking these questions, then I know if they have heard something that is uncommon, like, yes, I started taking cinnamon. or I started eating bitter melon to manage my diabetes, or I am now following a keto diet with intermittent fasting. So I am using the insulin plant now that I am having diabetes. So just by using those 4 questions, I can identify exactly what they're doing and not doing to manage diabetes or any other of their conditions. So you too can include that as an assessment so that you can then again bridge that gap to close those health disparities. Next. Now, this is a resource, adcs.findhelp.com, and that's to find free or reduced cost resources like food, housing, financial assistance, healthcare, and more. Ask your patient for the zip code, click search. Next. And I just click my zip code and I found 2517 programs. And as you can see here, food, housing, goods, transit, health, money, care, education, work, legal, help. Next. So education access and quality, people with higher level of educations are more likely to be healthier and live longer. Let me show you. Next. So here, this is age-adjusted prevalence of diagnosed diabetes by education level among adults age 18 or older. In the United States, this is the latest statistics by the CDC 2019 to 2021. You can see here the difference by men, women with a confidence interval of 95%. People without a high school diploma are almost twice as likely to have diabetes diagnosis compared to those with more than a high school education. So there you have it. So socioeconomic factors, those things do matter as well. Next, please. So health literacy, I mentioned that tool, the newest vital sign. You can just Google that, the newest vital sign, and you can keep that with you to assess health literacy. This is the Healthy People 2030 definition. It changed from just personal health literacy to personal and organizational health literacy. And again, is the simplest way that I use the definition is the ability of someone to take health information and put it into practice. Next. So let me tell you exactly the story of the child, the cereal and hyperglycemia. This is a true story of an endocrinologist that referred a child to me and her mom because she could not understand why the child was above target range, and the pediatric endocrinologist says, Lorena, please see this patient because I just don't understand. She keeps writing down everything that the child eats, and I don't want to increase her insulin to carb ratio anymore. I had the measuring cups on my desk, and she had written down that she was eating cereal. She had written down that she was giving the child 2/3 of a cup, and she had indicated the amount of cereal, that the carbs that she was giving the child. So I asked her, show me which cup are you giving your child? So she showed me the 1 cup measurement, and she showed me the 1/3 cup measurement. And she told me, this is what I give my child. This is what I use to measure 2/3 of a cup. So I said, these 2 cups? And she said, yes. So she showed me the 1 cup measurement and the 1/3 cup measurement. and she said, this is 2/3 of a cup. And then I realized that the mom did not know arithmetic. It was not an issue of anything else except that she did not know arithmetic. She thought that 2/3 of a cup was 1 cup plus 1/3 of a cup was 2/3 of a cup. So that first session with the mom, I had to teach her that 2/3 of a cup was 2 1/3 cups, or if she did not have the 1/3 cups, she had to use less than 1 cup. So I had to give her several samples of what it meant, because when there was a 1/4 cup measurement, she was using 1 cup and 1/4 of a cup. So everything, of course, was higher in the carbohydrate department because she did not understand the measurements. So when you tell people to read the food label, you're assuming that they know arithmetic. You do not know what they know unless you are checking. Next, please. So the consequences of limited health literacy, and this is an old study, but I just want to show you that even when it comes to take 2 tablets by mouth twice daily, you don't know what people know. And although 70% of patients with low literacy read at or below 6th grade levels, what percentage of patients were able to read the instructions? Only what percentage could demonstrate the number of pills to be taken daily? 35, 45, 50, or 60%? What do you think? You can write it down on the chat. And the correct answer is 35%. Yep. Next, please. The same thing. This study, the percentage of patients with an A1C of less than 7.2, the ones that had inadequate health literacy, 20% with adequate health literacy, 33%. Percentage of patients with an A1C higher than 9.5, the ones with inadequate health literacy, 30%, the ones with adequate health literacy, 20%. So even A1C and health literacy, you see that patients that have adequate health literacy have a little bit better management than those without. Next. So the impact of health literacy interventions on glycemic control and self-management outcomes among type 2 diabetes, a systematic review with patients from different countries, patients that were immigrants from different countries, have different views of the diabetes etiology. Some of them have concerns about insulin and about what insulin, the side effects of insulin, and also about how diabetes is managed. So how can you bridge the gap? What questions can you ask during the assessment? You can ask, what caused your prediabetes? What caused your diabetes? A simple question. It can generate the answers so that you can then bridge the gap. What concerns do you have about your medication or starting insulin or its side effects? And you can also ask, how is diabetes or prediabetes managed in your culture? Or And then that can give you the answers that you need when you're working with different cultures. Next. So the barrier of a low health literacy, low numeracy is about adding, subtracting, can lead to all this health disparities. So one way to do it is using teach back and teach back intervention. I want to direct you to this website, Agency for Healthcare Research and Quality. They have excellent tools that you can use for teach back. Teach back, I tell people to do two things. Tell me and show me. Tell me what are 3 things that you can do about hypoglycemia to treat hypoglycemia. Show me how you're going to do this. And this is a great place to go. And health literacy activities, go to the CDC. They have by state. Next. So teachback is a way for you to know if you're providing the correct information to your patient. So you can ask the patient or the family member to explain in their own words what they need to know or what they need to do. It's a way to check understanding. And then if they cannot tell you 3 ways that they can treat their hypoglycemia, then you need to teach it again. And if they cannot show you how they're going to plan their meal, then you need to teach it again. Next. For example, tell me, how many grams of carbs will you have if you have 2 servings of masa? A great way to do it. Can you show me how many units of insulin will you bolus if your meal had 50 grams of carbs and the insulin to carb ratio is 1 to 10? This way you know if you taught correctly. Next. This is the CDC website, Health Literacy Activities by State. And this is a snapshot of the Minnesota Health Literacy Partnership. And they have excellent resources. How can you teach? How can you write for patients with limited health literacy or partially limited health literacy? And here, there are different states that have health literacy, different states with different health literacy partnerships. Next. And these are resources for healthcare providers. This is from Minnesota. And next. And these are links to other organizations for health literacy, including a podcast, which I enjoy very much, Health Literacy Out Loud. Next. So 1 in 10 people in the United States don't have health insurance. And of course, they are less likely to have a primary care provider, and they cannot afford health services such as DS, EMS, and they cannot afford medication. Next. So again, what happens with lack of health insurance? Underinsured, cannot afford medication. Health beliefs and attitudes about medication is also very important. So I had included those questions before about asking individuals about how do they feel about their medications. Because even when they can afford their medications, we may be failing to ask how do they feel about taking their medications. And then there are certain communications about them. So we need to think about those barriers as well. And then what health disparities do they cause and how do we close the gap? And I have some assessment tools that I want to show you in addition to asking those questions about how do they feel about the medication and also about some of the cultural issues, which you, if you have those questions, you will be able to address them. Next, please. Okay, So I want to direct you to these questions that are excellent, and it's called your current life situation survey. And the link is right here, but you can also Google your current life situation survey, or you can just take a picture of this particular link. And this survey is excellent because you can access everything here: living situation, housing, food, utilities, childcare, and it provides you with information to address all this needs and how to refer it. Or you can go to ADCS Find Help to refer patients or clients there. Next, please. The other one, which is very extensive, and you can find an array of services, is the social determinants of health and practice improvement. There's an extensive list of tools and resources that you can use, and this is the link where you can find it. Next, please. Now, this is another pillar of the social determinants of health, and that is the neighborhood can also affect where we live in terms of not just where we are, but also when it comes to exercise. Next. And again, lack of unreliable transportation, and that could affect when we tell people just go out for a walk, etc. Transportation to attend sessions, and these are some of the things that can cause health disparities. So again, assessing first, finding those resources, referrals, suggesting telehealth visits. There's an array of YouTube exercise videos, finding out if delivery of medications via email can be something that could be helpful if going to the pharmacy may not be feasible, and exercising at home using YouTube videos could be helpful, and also telehealth and the assessment tools that I just showed you. Next, please. And then last but not least, social and community context, and that is being alone, mental health is very important. So interacting with other individuals is extremely important, and finding resources in the community for individual and with other persons that have diabetes. Next, please. Anxiety, depression, diabetes, burnout, or distress. There are DCME programs. The association, the American Diabetes Association, has some programs that are online. The Association of Diabetes Care and Education Specialists, they have a list of peer support communities that people can log in. Some of them are also online and in person. And again, all the assessment tools that are available. Next. Okay, so two things that I want you to think about in terms of things that are important about social connection. And one is what brings you joy, and that's just my question to you. And the other question that is more pertinent to this session is, what questions do you have? And I know that we are running late, but I am here to take your questions. And if for some of you only carved 1 hour, I will be more than happy to take your questions and you can either either send them to Bridget if she's okay with that, or you can send them directly to me because I have my email address here that you can reach out to me. You can visit my website. I have some information there, and you can follow me on Instagram if you wish. But you can certainly email me all your questions if you cannot stay, but I am able to stay, so I will be more than happy to answer your question. I know that I saw some questions about resistant starch.
Yep, that was the big question in the chat first was, can you give some more examples of resistant starch?
Yes. So resistant starch is food for your gut. That's basically it. Food for your gut. That is a prebiotic. And the reason that I did that social media on TikTok and Facebook was because I did it in Spanish, and that big yam that you saw, we made soup with that big yam. And it kind of tastes like a potato, but not quite. And we make that with vegetables, non-starchy vegetable to season that food. And more than half is resistant starch. So it does not elevate blood glucose as much. So that's the reason. And I wanted to dispel the notion for many Hispanics that have stopped eating yam because they thought that it would elevate blood glucose very high. So I told them that it contains resistant starch, which is a prebiotic, not to be confused with probiotics. So it feeds, it's not digested in the small intestine, but in the large intestine. And it elevates blood glucose, but instead of spiking it, it's slow and steady. Other foods with resistant starch are green plantains, not the yellow, but the greens. Also, for people that have diabetes, if you cook rice and then you put it in the refrigerator and then you warm it up again, the cooling of the rice creates that resistant starch. Other things that have resistant starch are legumes. So legumes, beans, peas, lentils also have resistant starch. Oats will have some resistant starch. They sell resistant starch now, and people add that to their meals to blunt the post-meal response. You still have to be mindful of everyone is looking for a diabetes hack. And unfortunately, there's no such thing. But it's nice to know that within appropriate portions, you're not going to have a huge rise on your blood glucose levels if you're eating appropriate portions. So legumes, green plantain, the yam, oatmeal, those are things that will have resistant starch. People are putting their bread in the refrigerator or the freezer, and then they toast it so that they can have a little advantage. I see that my camera decided to abandon me for whatever reason, but I'm still here.
Wonderful.
Is there anything else that people would like?
I didn't see any more questions in the chat. I just want to let people know that they need to do the survey at the end, the evaluation if possible. There's also a link in the chat and it's on the screen right now. To show the slides from the learning objectives again. Sure, I can do that. And then there was one question about how to lower your A1C, and I'll go back to the objective slide for you.
Yes. So to lower the A1C is a combination of taking medication as prescribed. That's number one. For patients that are taking medication, and that of course includes insulin, and that includes all medications prescribed for diabetes. Number two is physical activity. And then number three is a meal plan. And there are different meal plans that are approved by or recommended by the American Diabetes Association. But what I would say is, regardless of what meal plan a person chooses to have, what they all have in common is whole grains, um, such as I would say brown rice and whole wheat pasta and oatmeal and fruits, vegetables, legumes, nuts, seeds. I think that um, if you're going to have meats, it would be lean meats, eggs, soy products, if you're going to include soy products, and then fats, um, fats that have more mono and polyunsaturated fats that would come from, let's say, avocado, olive oil, etc. I think that when you look at in the world in general, diets that incorporate those foods seem to be the healthiest food. So I would say that those are the ones in appropriate portion for each individual. And of course, monitoring blood glucose so that the glucose stays within target range, and then adjusting accordingly.
Wonderful. Well, that is all the questions. Oh, I see. Um, we will be putting this recording on the Healthcare Homes webpage within a few days to weeks of this presentation. As Lorena mentioned, you can always feel free to reach out to her with any questions that you might have, and or we reference you to the Healthcare Homes and the Diabetes webpage on their MDH website. Thank you so much, Lorena, for all of your information. You were so wonderful. And we hope to have you back someday to even encourage us and educate us more of how we can help with SDOH and diabetes education.
Thank you. I hope that all the tools were useful to you.
Wonderful. Thank you so much.
Okay. Bye-bye.
Bye-bye.